Diuretics are chemicals that increase the rate of urine formation. They mainly promote the excretion of sodium, chloride, bicarbonate, and water. They also increase the urine flow, change urine pH, and produce change in the ionic composition of urine and blood. Classification of diuretics includes 5 main categories: carbonic anhydrase inhibitors, thiazides, loop diuretics, potassium sparing diuretics, and osmotic diuretics. First category is carbonic anhydrase inhibitors. These are sulfonamide derivatives that suppress the activity of carbonic anhydrase. Drug candidates in this category are acetazolamide, methazolamide, and dichlorofenamide. Second category is of thiazides. Thiazide refers to both a class of sulfur-containing organic molecules and a class of diuretics based on the chemical structure of benzothiazide. Drugs in this category include chlorothiazide, hydrochlorothiazide, hydroflumethiazide, and cyclothiazide. Third category is of potassium-sparing diuretics. They are weak diuretics, usually prescribed in combination with other type of diuretics. They are used to increase the amount of fluid passed from the body in urine. Drugs in this category are spironolactone, trimethoprim, and amiloride. Fourth category is of loop diuretics. Loop diuretics are diuretics that act at the ascending limb of the loop of Henle in the kidney. Drugs in this category include furosemide, bumetanide, and ethacrenic acid. Last category includes osmotic diuretics. Osmotic diuretics are substances that are freely filtered at the glomerulus but are poorly reabsorbed. Mannitol is the prototype of these diuretics. Next is mode of action of diuretics. In this picture, you can see the renal tubular system of human body. Diuretic drugs increase urine output by promoting diuresis. This is accomplished by altering how the kidney handles sodium. If the kidney excretes more sodium, then water excretion will also increase. Most diuretics produce diuresis by inhibiting the reabsorption of sodium at different segments of renal tubular system. Sometimes a combination of two diuretics is given because this can significantly more effective than either compound alone. This effect is known as synergistic effect. The reason for this is that one nephron segment can compensate for altered sodium reabsorption at another nephron segment. Therefore, blocking multiple nephron sites significantly enhances efficacy. The main site of diuretic action is well established for the different groups of diuretics. Carbonic anhydrase inhibitors act on the proximal tubules, loop diuretics on the diluting segment, thiazides on the cortical diluting segment or distal tubules, and potassium sparing agents on the distal tubules or collecting ducts. Now first of all we will discuss mode of action of carbonic anhydrase inhibitors. These are the weakest of the diuretics and seldom used in cardiovascular disease. Their main use in the treatment of glaucoma. Carbonic anhydrase inhibitors act on the proximal tubules. Bicarbonate absorption by the proximal tubule is dependent on the activity of carbonic anhydrase, which converts bicarbonate to carbon dioxide and water. CO2 rapidly diffuses across the cell membrane of proximal tubule cells, where it is rehydrated back to H2CO3 by carbonic anhydrase. Bicarbonate absorption is therefore dependent on the activity of carbonic anhydrase. Inhibition of carbonic anhydrase by carbonic anhydrase inhibitors results in an increased urinary loss of bicarbonate. This also interferes with the reabsorption of sodium and chloride ions. The basolateral sodium-potassium ATPase maintains a low intracellular sodium concentration, which is necessary for reabsorption of sodium, and in the proximal tubule also facilitate the efflux of H positive by sodium proton exchanger on the luminal site. Increased delivery of the sodium to the collecting duct results in reabsorption of sodium in exchange for increased potassium efflux, which can cause hypokalemia. Next mode of action is of thiazide diuretics. Thiazides acts on the cortical diluting segment or distal tubules. Because this transporter normally only reabsorbs about 5% of filtered sodium, these diuretics are less efficacious than loop diuretics in producing diuresis. Nevertheless, they are sufficiently powerful to satisfy many therapeutic needs requiring a diuretic. Their mechanism depends on renal prostaglandin production. Thiazide diuretics compete for the chloride binding site on the Na-positive Cl-negative cotransporter that is selectively expressed in the distal convoluted tubule, inhibiting its ability to transport ions. Inhibition of this cotransporter lowers intracellular Na-positive, which in turn results in a lowering of intracellular calcium mediated by Na-positive Ca2 positive exchange expressed on the basolateral membrane. This facilitates the diffusion of calcium through calcium ion channels expressed on the luminal membrane. The inhibition of Na-positive transport in this segment results in greater delivery of sodium to the collecting duct, where enhanced sodium influx through epithelial sodium channels stimulates potassium efflux, which can result in development of hypokalemia. This transporter normally reabsorbs about 25% of the sodium load. Therefore, inhibition of this pump can lead to a significant increase in the distal tubular concentration of sodium, reduced hypertonicity of the surrounding interstitium, and less water reabsorption in the collecting duct. This altered handling of sodium and water leads to both diuresis, which is increased water loss, and natriuresis, which is increased sodium loss. By acting on the thick ascending limb, which handles a significant fraction of sodium reabsorption, loop diuretics are very powerful diuretics. These drugs also induce renal synthesis of prostaglandins, which contribute to their renal action, including the increase in renal blood flow and redistribution of renal cortical blood flow. By reducing the lumen voltage gradient that drives cation reabsorption in the loop, loop diuretics increases the excretion of divalent cation such as calcium 2 positive and magnesium 2 positive. This can be useful in treating disorders causing hyperkalemia. This is an effect opposite from that caused by thiazide diuretics. Mode of action of potassium sparing diuretics. They are called potassium sparing diuretics because they do not produce hypokalemia like the loop and thiazide diuretics. The reason for this is that by inhibiting aldosterone sensitive sodium reabsorption, less potassium and hydrogen are exchanged for sodium by this transporter, and therefore less potassium and hydrogen are lost in the urine. Other potassium sparing diuretics directly inhibit sodium channels associated with the aldosterone sensitive sodium pump, and therefore have similar effects on potassium and hydrogen ion as the aldosterone antagonist. Their mechanism depends on renal prostaglandin production. Because this class of diuretic has a relatively weak effect on overall sodium balance, they are often used in conjugation with thiazide or loop diuretics to help prevent hypokalemia. Last mode of action is of osmotic diuretics. Osmotic diuretics are filtered and increases osmotic pressure in tubular lumen. Hence increases excretion of water and electrolytes like Na positive, K positive, calcium 2 positive, magnesium 2 positive, HCO3 negative, and phosphate. They increases the volume of urine and rate of urine flow through the tubule. Mannitol is a sugar alcohol that does not cross cell membrane and acts as an osmotic diuretic that inhibits sodium and water reabsorption in the proximal tubule as well as the loop of Henle. It produces a greater loss of water compared to sodium and potassium. Mannitol can also reduce brain volume and intracranial pressure by osmotically extracting water from the tissues into the blood. A similar effect occurs in the eye. Thank you.